Hello, this is Maxwell Bowman, Nursing Level 2, part of Mrs. C's class. Today I'll be talking about diabetes, gestational diabetes, how it affects mom, the fetus, and neonatal. Diabetes is a major pregnancy concern that affects both the mother and fetus. It has lingering effects on the neonatal even after birth. Even if a mother doesn't have diabetes, it's quite common to be acquired with first onset of pregnancies. The definition of which being gestational diabetes mellitus. This is very relevant for pregnancy, especially as a nurse. Gestational diabetes mellitus is glucose intolerance with its onset during pregnancy, usually around the 24th week or first detected pregnancy. The prevalence of gestational diabetes has been increasing in the United States and is high as up to 10% right now. Gestational diabetes is associated with either neonatal complications such as microsomia, hypoglycemia, birth trauma, or maternal complications such as preeclampsia and cesarean birth. We'll go into macrosomia, hypoglycemia in a bit. All women of childbearing age with diabetes should be counseled with the importance of strict glycemic control prior to conception. Just basically, you have diabetes, you need to understand how this is going to affect your pregnancy and possibly your child. So if you are trying to conceive, you're on that path, you really need to get your glucose levels in check. Otherwise, it's not going to go well. Observational studies have shown an increased risk of encephaly, macrocephaly, and congenital heart disease. Apologize if I didn't say the previous two correctly. And those are going to increase directly with elevations in their A1C. Typically, at around 24 weeks is when the insulin resistance test is given. That's where you first test for gestational diabetes. And after which the insulin is shown high, then there are going to be a lot more tests just to follow up, like, hey, let's confirm that you have acquired gestational diabetes. If you already had diabetes, that's known as pre-gestational diabetes, and that includes type 1, type 2. The reason we go into this, reason it's so important, just to list off what it does to the mother, just like quick bullet points. Hydroamnios due to fetal diuresis caused by hyperglycemia. So basically, the infant or the fetus is having so much sugar, and it's the same symptoms as with an adult. It's causing polyuria, so they're just constantly pissing in the womb. It's going to cause gestational hypertension. It's not really known why that's caused, the direct etiology, but you can basically assume all that sugar is running through the blood, causing the pressure to increase. Ketoacidosis due to controlled hyperglycemia, which that one's given. No need to go into that. Preterm labor, secondary to premature membrane rupture, and cause stillbirth and pregnancies complicated by the above mentioned ketoacidosis, and of course being due to poor glucose control. Hypoglycemia, as glucose is diverted to the fetus, so like the little bit of sugar the mother's actually getting is actually going to go to the fetus. It's going to cause UTIs, which is because all that sugar in your blood, it's promoting bacterial growth, especially in the vagina. So that's going to cause possibly an STI. Bacteria in the vagina is ascending typically, so that can reach the fetus, cause plenty of issues there. It can cause chronic millennial vaginitis due to glycosuria. It's going to promote growth of yeast, so that's basically reiterating what I said. And then difficult labor due to basically once you develop gestational diabetes, the child itself is not going to be getting enough glucose because it's kind of relying on you. So what's going to happen is the child is going to start using its own pancreatic cells to produce insulin, and basically that's going to cause the infant to basically grow to possibly like a 9-pound infant. After that, you have to get a C-section. It's going to cause health issues afterwards. That's just more of the broad strokes. That was more affecting the mother, but specifically the infant. What can happen with this is it can cause congenital anomaly due to hyperglycemia in the first trimester if we don't identify it quickly and address it. Once again, just going to macrosomia, the birth size is going to cause possible birth trauma, tearing, dislocation, just anything bad that can happen will happen. Fetal asphyxia, secondary to fetal hyperglycemia and hyperinsulinemia, and it can cause intrauterine growth restriction, secondary to macular or maternal vascular impairment and decreased placental perfusion, which is going to restrict growth. And then, of course, reiterating how deadly it can cause perinatal death due to poor placental perfusion and hypoxia. It can cause respiratory distress syndrome resulting from poor suffocant production, secondary to hyperinsulinemia, inhibiting the production of phospholipids, which make up the surfactant. If you see my hands moving around, my cat's jumping on me. Come here, kitty. And then, of course, neonatal hypoglycemia. So even though it's away from the mother, those effects, those symptoms of diabetes are gonna still linger after birth. So the infant can come out hypoglycemic, which is not good whatsoever, and especially after the placenta is removed. And then once you kind of come out that way, think kind of like crack babies, even though you didn't do crack, you're susceptible to addiction, and these macrosomia babies come out and they're probably going to have to deal with childhood obesity, carbohydrate intolerance, and just kind of deal with these effects throughout the rest of their lives. Now, because this is so important, it's really important to stress to the mothers having to deal with gestational diabetes. Like, even though this may not necessarily be your fault, your body's going through changes you can't really help, you need to make lifestyle modifications. Lifestyle modifications, nutritional changes, and physical activities are going to be your primary forms of therapy for diabetes during pregnancy. Therapeutic management for the women with gestational diabetes mellitus focuses on tight glucose control. So we really want their fasting blood glucose levels to be below 92. In comparison, for pregnant women without diabetes, their fasting value is somewhere between 60 and 90. In addition, maternal pre-pregnancy weight and gain during pregnancy appears to be significant, and independent risk factors. I'm sorry, I typed that wrong. You really, yes, you're going to gain around 50 to 20 pounds once you're pregnant, but you really shouldn't be pushing past that. Yes, we want you to consume more calories. Yes, we want you to eat more. That doesn't necessarily mean eat a whole container of Drake's coffee cakes. When these lifestyle changes are failing, maybe it's thyroid problems, the deck's really not in the pregnant woman's favor, or they're just non-compliant, we're going to have to resort to pharmacological therapy. Blood glucose levels in the woman can be controlled by nutritional therapy and exercises, but in uncontrolled cases where target glycemic levels cannot be reached, insulin is also required. Insulin, it does not cross the placenta, which is a good thing, and it's the medication of choice for treating hyperglycemia in pregnancy. We calculate it based off the woman's weight, and for pregnant women, we really want to combine intermediate and short-acting insulin, because that's going to yield the best results. The routine here is we want 2 doses given daily, one in the morning, and basically a third, like a smaller dose at night, and that's basically going to be our best choice for treating that. That's 10 minutes, so as much as I love talking, I think I'm going to cut it here. Have a wonderful week.